great time since morning. And for this session, we have two special people, and it's my absolute pleasure to introduce Dr. Katia Bilardo. She is the professor of medicine at UCMG in the Netherlands and also emeritus professor in the University of Groningen. She's an expert in ultrasound and invasive prenatal diagnosis. After completing her medical studies, she trained as a fellow in prenatal diagnosis and fetal medicine at the King's College Hospital under Professor Campbell and Professor Kypros Nicolaides. Since 1989, she had relocated to Netherlands and worked as a consultant and head of the prenatal diagnosis department at the Academic Medical Center in Amsterdam. Since then, in 2010 to 17, she has worked as head of the fetal medicine department at the University Center Groningen, where in 2011, she's been appointed as professor in fetal medicine. Subsequently, since October 2017, she has moved with the same position to Amsterdam UMC at the VU Medical Center, where she has also been appointed as professor of obstetrics and gynecology and fetal medicine. In the Netherlands, she's been the president of the Dutch Working Party for Ultrasound and Obstetrics and Gynecology and is currently member of the Committee Prenatal Screening of the National Health Council. But there are some very special facts about her. She's a past president of ISUOG, and also since 2007, she is in the editorial board of Ultrasound and Obstetrics and Gynecology, and since 2009, board member of the International Society of Ultrasound in ONG. She was also the chair of the Education Committee with ISUOG, and in 2018 to 20, she's been the president of the society. Over 200 peer-reviewed articles, supervised numerous PhD students, and in 2021, she was bestowed the Stuart Campbell Award for Education. Her research areas include Doppler study of the uteroplacental fetal circulation, fetal dysmorphology, first and second trimester ultrasound screening for aneuploidies, first trimester ultrasound, psychological aspects of screening, fetal cardiology. And I should add that anytime you want any help from her, she's readily available, especially in the aspect of ultrasound education. Thank you, Katia, for being here today. Professor Rabi Choi was born and schooled in Beirut in Lebanon. His medical studies and specialization in obstetrics and gynecology were undertaken at Charité Medical School, Humboldt University in Berlin, Germany. Between 2001 to 2004, he was professor of obstetrics and gynecology at Charité University Hospital, Berlin, and since 2004, he has worked at the Center of Prenatal Diagnosis and Human Genetics in Berlin. An ISUOG member since 1994, he has been a board member from 2003 to 13, including 2 terms of chair at the Education Committee, and received the Stuart Campbell Award for Education in 2018. Professor Rabi Choi is best known for his wonderful books on fetal ultrasound, including the Fetal Echocardiography book, which consultants and students around the world look up to whenever they have a problem. Since 1986, his major interest has been fetal ultrasound to include fetal heart, fetal 3D, first trimester ultrasound, ultrasound in genetic disease, and high-resolution ultrasound. So it's a privilege and pleasure to introduce Rabi Choi and Katia Bilardo. I invite Katia to give her lecture. We will have both the lectures, and then we will have a discussion session. Thank you.
Thank you very much, Suresh, for such an extensive presentation. It is my great honor to be here today, and I really want to thank enormously Kypros Nicolaides, who together with ISUOG is offering so many people such precious moments of education. What I'm going to discuss with you today is the impact of ultrasound screening on the detection and outcome of cardiac defect. So I will set the scene by underlining the fact that ultrasound investigation, at least in Europe, is extremely popular. There is virtually no woman in Europe who doesn't get a scan in pregnancy, and the number of scans vary among countries depending on local protocols. And ultrasound in pregnancy is really a very essential part of the pregnancy and birthing culture, and we couldn't think of a pregnancy without it. And when the health service fails to provide enough scans to satisfy women's need to see and meet their unborn child, then women will go to these scan for fun offices. The rationale behind ultrasound investigation in pregnancy is that it should lead to more healthy children. It should lead to early recognition of fetuses with anomalies, with the option of terminating the pregnancies, and provide an opportunity for organizing optimal care and therefore better outcomes of affected fetuses with a positive effect on families' well-being. And obviously, in case of multiples, growth restriction, infections, and all the problems that you have already heard today, ultrasound will allow us the opportunity to institute optimal monitoring and care. Many countries have adopted already for decades a protocol for routine second trimester anatomy scan. ISUOG has also produced guidelines, and these have been recently updated. And as far as the heart is concerned, I will discuss what are the views that we recommend. But I want to take you back to the history of routine ultrasound screening. And if we look at this slide, we see that at the beginning, in the year, at the end of the 80s, the beginning of the 90s, was rather dramatic, because this study, the radius, showed that the impact of ultrasound screening on the detection of congenital anomalies was in actual fact very, very poor, 17% detection. And then things started gradually to get better. But what is very interesting to see is that, for instance, if you look at Helsinki, the city of Helsinki, and two studies performed in the same years, 86, 88, you will see that at the Helsinki City Hospital, detection rate was 36%, whereas at the University Hospital was 77%, meaning that knowledge and experience are crucial for good results, the good results that, for instance, are also booked in other centers of excellence. And again, in Helsinki, there was the first trial that showed that ultrasound screening has got an impact, a positive impact on perinatal mortality. And what they in actual fact showed on about 5,000 patients was that comparing a group exposed to ultrasound screening with a group where no screening was offered, the perinatal mortality was significantly lower in the screened group, with a 50% reduction in perinatal mortality. But looking closely at this was mainly due to improved early detection of major malformation, which led to termination of pregnancy. So there was really a shift of in perinatal mortality from after birth to before birth by having more termination in case of anomalous fetuses. Well, it's not new to you that we are talking today of cardiac defects, and these are very important defects because they are very common and they have a huge impact on neonatal and childhood deaths compared to other anomalies. And unfortunately, this is the dark side of the story. We know that ultrasound detection of cardiac anomaly is very challenging as compared to detection of other anomalies in other organ systems. And here it is stated 30%. Well, now the situation has much improved, but it is still very challenging, and I think especially in low-income countries. So when we started with non-targeted examination and without real standardized protocols, the detection rate for cardiac anomalies was extremely low, not more than 50%. Then the 4-chamber view was introduced. There was more training offered. There was a targeted fetal heart examination. And then there was a dramatic improvement to about 40%. Then the extended examination, the extended view, and I will discuss that later, was introduced. There were more specialized centers. And by adding to the 4-chamber view the great vessel view, the outflow tracts, the detection rates, at least in the centers of excellence, has increased up to about 80%. So there are 5 short axis views, and this was proposed by Diego in 2001. And as you can see, you can really perform 5 different cuts through the fetal body. And by starting with the situs view, just above the abdominal circumference, we move to the 4-chamber view, and then a little bit higher up, the 5-chamber view with the left outflow tract, and then a little bit higher up, the pulmonary artery, the right outflow tract, where we see also next to the pulmonary artery, the aorta and the superior vena cava. And we see in actual fact where the aorta and the pulmonary artery, the 2 ducts in actual fact, the aortic duct and the pulmonary artery duct meet each other and form this V sign. And in the same view, we can also see the trachea as a kind of a very white spot behind the superior vena cava and next to the aortic duct. It's very important when we talk of screening that we have robust data in order to be able to judge on the impact of screening. And this is very challenging because it means that we need a very good registration, not only of prenatal data, but especially of postnatal data. And this registration must be long enough, and it requires communication between neonatologist, pediatrician, cardiologist, and et cetera, et cetera. So what I want to show you here is some data from the Netherlands after our screening program was instituted in 2007. And what you can see here is the proportion of terminated pregnancy. And I show you now spina bifida as an example, and we can see that before screening, there were 34% termination of pregnancy because obviously there were some scans happening. These went up to 48% after the screening was introduced. And a few years later, when expertise with screening was acquired, it went up to about 66%. If we move to hypoplastic left heart syndrome, we see that before screening proportion of terminated pregnancy was about 18%, 50% at the beginning of the screening, and 56% a few years later. Again, data from my group in Groningen, and here I show you the trends in detection of severe anomalies before the screening was instituted in 2007 and thereafter. And we can see that throughout the years, postnatal detection became lower and lower, meaning that screening was effective in moving the detection from after birth to before birth. And this is obviously what the screening is about. And if it comes to the outcome of the diagnosed cardiac defects, again in the same window, we can see that termination of pregnancy becomes more and more important after screening has been instituted, because more anomalies are detected prenatally and patients have the option to terminate the pregnancy. I'm aware of the fact that this is not an option everywhere, all over the world, but fortunately in our situation it is, and until 24 weeks, families can choose for termination of pregnancy. Let's have a look at what has been the interaction of prenatal screening on the postnatal context. So on the one hand, we have first trimester and second trimester ultrasound, and we have first trimester markers. They have already been named, and many second trimester markers of cardiac anomalies that I will not mention. And this allows the opportunity for parents to choose for termination of pregnancy. And we know that if in some very severe cases, the fetus may die in utero, even if it is not chosen for termination of pregnancy. How this increased prenatal detection has impacted the postnatal presentation of cardiac anomaly is very important to know. First of all, we have a clear reduction of complex cardiac defects cases postnatally, due mainly to termination of pregnancy. So there is a completely different spectrum in between the prenatal presentation and the postnatal spectrum of cardiac defects as seen by the neonatal cardiologist after birth. Also, in some cases with some anomalies, it has been shown that there has been a reduction in morbidity and immortality. And this is for sure the case in there where transposition of the great vessels is concerned. And thanks to the fact that our knowledge has increased, also the surgeons, the cardiac surgeons that are concentrating more and more care and specializing on dealing with a certain heart anomaly have achieved much better results than in the past. Again, in the Netherlands, and this is Leiden, the effect of screening, of a standardized screening, has resulted in an increase by 24% in the detection rate of cardiac anomalies, from 36% to 36 to 60% of all the cardiac anomaly. And in case of isolated cardiac defect, this has improved from 23% to 44%. About 93% of the hypoplastic left heart syndromes are currently detected in the Netherlands, and also the late referrals for cardiac anomaly have dramatically decreased thanks to the fact that anomalies are detected at 20 weeks. Also, in case of transposition of the great arteries, which we know it's a very challenging prenatal diagnosis, about 27% of these are now diagnosed prenatally. Quality controls of the sonographers. And this is a very interesting paper from the group of Monique Haak, published in ISUOG, and I would really invite you to read it, which is discussing why cardiac defects are being missed. They addressed 114 cases of isolated severe cardiac defects, and about half of these, 51, were missed. And they analyzed specifically why they were missed. And the reasons were either low quality of the picture or low quality examination of each individual cardiac plane. And here there are the specific percentages that I will not mention. And also the poor use of magnification. There were obviously situations where the cardiac examination had an inadequate quality score and the heart defect was not clearly visible. Or there were situations where the defect was clearly visible, but was not recognized by the sonographer. And then other situations where the defect was not visible, despite a very adequate quality of the picture. So in this table that I will not really discuss with you, invite you warmly to look to read this very interesting paper. A number of anomalies where cardiac defects were missed, were analyzed for these three different possibilities: either lack of skills or lack of recognition, or lack of visualization that they call inevitable. And I show you just some examples. For instance, this is a case of ABSD, and it is clear that the skills of the sonographers were not sufficient to recognize the anomaly. These were two cases where the anomalies were quite clear in the pictures. The pictures were of good quality, and they were also clearly showing the anomaly, but they were not recognized. So denouncing the fact that there was enough skill in the sense of recognition of the anomaly. And then there was this third case of a cohort where the pictures were very good quality, but the coarctation was missed inevitably, because we know that it's a very challenging diagnosis, and it's inevitable that some cases will be missed. So the bottom line of this paper is that quality is essential for prenatal detection of cardiac defects. And it's also very important that sonographers are exposed to a high volume examination, that they have decent equipment, and that training at least 80%. So you may argue, if it's so difficult to achieve a good detection rate, and if it's so operator dependent, why don't we think of another tool to detect cardiac defect? And this was in actual fact suggested by by a number of papers, suggesting the use of pulse oximetry screening as a tool, very easy to use and not operator dependent, to identify at least the anomalies that are characterized by giving hypoxemia after birth. But the fact is that although this tool may be very good for recognizing, for instance, the transposition of the great vessels of hypoplastic the diagnosis of congenital heart defects and the different sources of mortalities and morbidity with all the intervention For instance, this paper from France again, two regions in France with 250,000 deliveries, 677 cardiac defects. Prenatal diagnosis was very, very good. 72% of the cases were diagnosed, and they were subdivided in 3 groups. 98% detection rate in the cases where no anatomical repair is possible, 64% in cases where repair is possible, and there may be a need for emergency neonatal and cardiologic assessment management, like for instance in balloon septostomy in case of transposition of the great arteries, and 66% in cases where the repair is possible and there is no need of neonatal cardiologic management. However, in spite of this very good detection rate, when focusing only on deaths due to cardiac defect, there was no impact of prenatal diagnosis on deaths. So it's a very complex story. And the effect of mortality may be due to more termination of pregnancy and increased survival of cardiac defect needing timely neonatal intervention. But the effect on perinatal morbidity is much more complex to discuss and to analyze. Do we talk about neonatal morbidity or later in life? We know that some defects will only become apparent later in life. Which kind of tool will we use to intervene? In utero intervention, optimization of diagnosis, tailored postnatal management by better stratifying the risk according to the type of cardiac defect and offering tailored care? Or do we talk in terms of impact on neonatal distress? We know that maybe neurodevelopmental outcomes and quality of survival may be favorably impacted by prenatal diagnosis. So in conclusion, there are a lot of open issues, and without mentioning cost benefits and also the discussion on the parental psychological consequences. Is it really good for a parent to know very early in pregnancy that the child has got a heart anomaly? Will not create too much unnecessary anxiety without really modifying the prognosis. So, and I jump now to the conclusion of my talk, and this is that the usefulness of prenatal screening for cardiac defect is at the complex frontier between congenital cardiology, healthcare organization, philosophy, and metaphysics, and there is no scientific truth in this field. Continuous sharing of clinical experience and interaction between various disciplines will further increase knowledge and lead to fruitful innovations. And I firmly believe in this. Our mission is to contribute to improvement in diagnostic skills and knowledge on congenital heart defects. And that is why we are here today. And I thank you very much for your attention.
Thank you, Katya, and absolutely lovely lecture. And you've given a very important message that the truth is not out yet. And I think that's one of the things we will discuss. So may I invite Ravi Chavi for his lecture, please?
Thank you, Dr. Suresh, and thank you, Katya, for this nice overview. Even one of the last sentences where it is really complex, so this is why we will discuss this also later on. At the beginning, when I was asked to give a talk on the fetal heart, and I'm really grateful to Professor Nicolaides and Professor Liana Poon for this kind invitation today. I assumed I will show you images on how to perform the fetal heart examination and like in our book. But I think the more we're discussing that there are some issues to be discussed today, I put some thoughts on improving the detection of congenital heart defects. So if you look at the WHO on screening programs, because we are working with screening, we should consider effectiveness, we should consider the benefits to be maximized for patient safety, and also and don't forget to minimize harm. So this is one of the main aim we should keep aware when we discuss issues of screening. But in my opinion, congenital heart disease are a good example of positive aspect of screening pregnancy, because, you know, even if we do nuclear transfusion and so on, but this aim is really we can reduce mortality, because most cases isolated will be prepared to have a good surgery after birth and not, let's say, mainly to detect in order to terminate pregnancies. This is why at the beginning, if you want to do a good screening policy, we need some health system offering this. And this is how it started almost 50 years ago. So with Laurent Fermont and Lindsay Allen in UK and in London and in Paris, both pediatric cardiologists said something very simple, actually. The formula is quite genius. They said, we have in many countries an established screening of second trimester scan. Why not to teach obstetricians or sonographers to look at the heart, but this way we can discover cardiac abnormalities. And they said also that there are patients at high risk for congenital heart diseases. They should be referred to a center specialized on this field. However, we have to focus on screening policy and how to perform screening. And it is quite simple. Look at the 4 chambers, and then you will detect the abnormality, and you send us to the center. So this is theoretically possible, but practically we have been working on this field since the last 40 or almost 50 years. This is why what we need in order to have good screening, we need excellent sonographers. And what is an excellent sonographer? If you know this book from Malcolm Gladwell on the 10,000 hour of intensive practice until you get to be an expert, it seems that I counted, if you perform 5 or 6 days a week, you will have 7.5 years to be expert. But in my opinion, let's say, to be a very good sonographer, you need 2 years of continued work, and then you can do very good scan. And then the question is it enough at the end to make high detection rate? An ultrasound specialist, in my opinion, and I hope you'll share this with me, is a really multi-talent. You need to be a technician because you need to work on the machine, to change the knobs and so on. You need to be an artist to produce good images. You need to be a psychologist. For the one, you will smile. With the other one, you tell her that the baby has a disease and will not survive. You are also, at the same time, a scholar, because you have to have a huge knowledge. You'll see why. But at the same time, you're always a student, learning every day new things, but also teaching the younger generation. And last but not least, you need to have visual intelligence in order to identify the normal from the abnormal. And you have also to cope with errors, because you cannot succeed your career without doing errors and learning not to repeat them again. So you see, you have different tasks to do on the day, and not only to measure the BPD and the abdominal circumference. This is why what we need are definitely guidelines and the systematic examination. And this was a tremendous progress in ISUOG when we started writing the guidelines in 2006, but there has been a development over time. So this is where we started, and we're happy at the beginning to write anything on the paper. So this is one of the earliest guidelines of ISUOG, where we decided to have a basic cardiac examination, means the 4-chamber view, and when technically feasible, you call it extended basic, and you look at the great vessels. But you know, like me, that even 2006, it was already too late to give it this as basic, when technically feasible. We're doing this, but we wanted to start, let's say, in a simple way. And you have seen this data from presented also by Katya, that if you perform the 4-chamber view and you have some trade person only, you will reach not more than 30%. In general, it's always half of this, so you may reach 30% or 25%. This is why we knew just at the beginning they are almost stillbirth, these guidelines, and we need to have newer one where we include the great vessels. And this was done a few years later, 2013. In general, you need 2 years in order to finish such guidelines, to let people agree on the conditions. And then we said what is today acceptable. You start from the upper abdomen, look at the 4-chamber view with different features, you look at the outflow tracts, and then you will terminate by having the 3-vessel TACV, which became then popular. In addition, when technically feasible, or when you are confident by using it, add color Doppler. Now, 10 years from now, 10 years later, and these are the one which are going to be published in the next few weeks. You will see them in the White Journal. This is here a brand new things, and Dario and other were working with us on these guidelines. You see here the upper abdomen. In these terms, we added now the color Doppler to it. We have new schemes. You see the cardiac axis developed by Franti Grochal. You see the four-chamber view in 2D and in diastole on color Doppler, the outflow tract, and the short axis or the right ventricular outflow tract view and the three vessel trachea view. And we developed the issues of how to discover the anomalies. So you see, we have the technique, but why are the detection rates not going up with our guidelines? Because we have a major problem, and this is what I want. One of the major issues I want to address today in my talk is many people and many centers, especially when you are training either young fellows or sonographers, they consider ultrasound according to guidelines as a checklist, as a laundry list or shopping list. They have to store images of planes and then they are done with the examination. And you have seen the images shown by Katya before, so it looks the same. And I would recommend you to read this article by Mark Slansky from LA with Greg Devore. They said why our guidelines are doing wrong, because they said many people of us are focusing not only they should not focus on getting the required grade, but also on good image quality. And this is really underestimated until now. We tell them you have to get these planes and then you are done. And this is why it can depend on fetal position, it can depend on insulation angle and how to get closer to the fetus. So this is the image quality, I think, is going to be an important issue in the near future in order to improve our detection policy. So you'll agree with me, this is a four-chamber view, but this you will find in some institutions. So what you need to do is to export this to have such a picture instead of this smaller one, because here you cannot read anything on this heart. And this is why train your people to magnify the image. And since the nuclear translucency, you know how to magnify the image and how to use the scene loop in order to get the perfect plane. So this is why please work on this. I will present again the paper from Van Nistelrooy. Katya presented before, showing you why, because now you know the data, they have 92 anomalies, this divided into two groups, the undetected, detected one, and they were seeking for the reasons of why they were not detected. And they found out, among others, that the quality of the planes, most important determinant for prenatal diagnosis, and the quantity the ultrasound person was doing improves also the quality. So in other words, if you want to improve your work, you need to have someone working for longer than a period of time, but also someone producing good images. And I think one of the possibilities in future is to work like the Fetal Medicine Foundation. That means you ask in a unit that they send you the images of the four-chamber views or the great vessel to see if the quality is, let's say, as should be. And this is why the technical aspects are crucial. So I think these are the things you know. We need to know which probe to use, how to deal with the machine, to adjust the preset, how to optimize on 2D and color Doppler, and taking your time. So I'll show you this picture of the machine I'm using, and there is no brand of the company, I hope. See, and you know, some patients, the husband of the patient asked me, but do you know all the knobs? I said, of course I know the knobs. So imagine yourself how many of these knobs and the touches here you know on your machine. And imagine you are sitting in a plane and you enter the cockpit and you ask the pilot, excuse me, sir, do you know all the knobs? He said, no, I don't know. I need only to take off and land. These are, let's say, I don't know what for, but I have an autopilot. It will do the work for me. I don't think it will give you a safety aspect that if he doesn't know or she doesn't know the different tier knobs, what to do. This is why, please remember how many of the knobs and of the presets you know on your machine. And this is something we should work on in order to get a good image. This is why, in my opinion, people ask me, what can I do in order to get a good cardiac diagnosis? Before you learn the cardiac anomalies, please spend 80% of your time on getting a good image, because the good picture is a secret of the successful diagnosis. If you don't see in magnification the normal heart, how are you able to see an abnormality? So this is why the good image is, let's say, the secret of all. Now, what is under discussed and almost never discussed is a scanning environment. No one discussed on this condition. So this is here, I had to make this quote. I asked my nurse, please, you have to do it. because this was a lady without a mask here during the COVID, and she's alone, so she brought her daughter with her. The daughter was crying, and then I said, keep cool. I did my breathing exercises and was scanning, and it reminded me when you go in the bus and children are crying and shouting, please don't talk to the driver. So I was focusing on my work, but this aspect we don't discuss. We don't discuss the issues of distraction. We don't have a telephone. I don't have my cell phone close to me in my scanning room because it is distracting. Do we have enough breaks? Diversity of scan. If you scan the whole morning, only second trimester scan, you'll forget, have you seen the hand on this fetus? Oh, I saw it, but are you sure? Was it on that one or on this one? This is why try to take one second trimester, one first trimester, one Doppler third trimester, or one anomaly scan, one scanning an anomaly, and by diversity, you can better focus on your examination. This is why we discussed the two aspects, and now we finish. The third part is you should know the typical heart anomaly, and this is what Katya was discussing with you before, saying we need to show people how the anomalies look like, either on let's say on a simulator or otherwise. So in this paper, again, we showed you the first one. Interestingly, and this is scaring, 30% of the anomalies were visible but were not recognized. So you look at the picture, said, but how did this person look at this picture, stored it, and did not recognize that it's abnormal? Because you need a visual intelligence. Not everyone can see the same. And I think also it is a problem of our teaching. And in many places, when you go to listen to talks, you'll see they give a talk, and some will list some anomalies showing, oh, you see the aortic stenosis disease occurring in 5% of all anomalies, and so on and so on. And this is not how we are detecting them. What we should teach is more to focus on the symptom, because this is what we see. We see image of the 4-chamber view, and we look at the 5-chamber view, and we see a thickened aortic valve. Then we discover the aortic stenosis. We don't know the names, but we should know what is normal and what is abnormal. This is why what you should teach is rather the symptoms and the hints leading to an abnormality, and not the anomaly as definition of an AV septal defect and so on. So in other words, let's have a look to these abnormalities. The teaching is to how to analyze the spleen. For example, some of the 4-chamber view are obvious, a large heart, a tumor, or this 4-chamber view is quite abnormal because it has one ventricle here, there's one ventricle here. You don't have the 4-chamber view, and these are obvious. And these are the one in many of these studies where you see 20%, 30%, 40% of hypoplastic left heart syndrome are detected. But for example, this one here, why are these rarely detected or occasionally not detected? Because the analysis of the plane is more counting the chambers. And you see in hypoplastic left heart syndrome, in this case, you have 4-chamber. In coarctation, you have 4-chamber. In AV canal, you have 4-chamber. But we should teach people how to see that this abnormality is there, or why there is a linear insertion of the valves, or why the apex of the heart is not formed by the left ventricle, or there is less contractility on the left side. So these are the keys to teach, and not to say 4-chamber view and no one is telling you what to look for. So, and I want also to encourage people to use the color Doppler, because we have no more and more, let's say, an epidemic of obesity. And if you don't see anything, you see in this dual picture here that we are able on the right side to see the filling of the ventricles. So we are almost ruling out many of the anomalies of the 4-chamber view because we use the color, but on 2D, you cannot recognize anything. So theoretically, this is at the end, what should be achieved to have the upper abdomen, the 4-chamber view, and you have seen the planes here until the 3-vessel trachea view, exactly what is now required from the ISUOG guidelines. But now, why is cardiac anomaly so difficult? Because we have numerous very well-known cardiac abnormalities. And if I take only 2 planes, the 4-chamber view and the 3-vessel trachea view, look at the 4-chamber view, these 12 anomalies. Actually, the one doing the scan should be able, at the end, as a semi-expert, to know the diseases like VST or AVST or pulmonary atresia and so on, and to know the association with anomalies, to know what are the features in color Doppler, and how to counsel the patient in a way. So what this outcome is going to be, univentricular heart and so on. This is only for the 4-chamber view. Look at now the great vessels. You have here 27 different conditions. So if you put all these together, at the end, the one doing the scan and getting 5 planes should know in his mind or her mind some 60 different pictures of an abnormality. And this is quite impossible to expect that it will be so easy. This is why I'm sure we need to change something in our behavior until we reach, let's say, a success. And one of the major problems, and this is, I think, something more psychological, is in the 90s and the 2000s until recently, let's say, we were proud to be able to detect anomalies. So we have detection rate in some centers increasing from 40 to 60, but the expectation of the patients and for all caregiver have increased. And now people are disappointed that they know that they are going to a special center to get anomalies ruled out. They start taking folic acid in early gestation, before gestation, to avoid spina bifida. And you cannot tell them, oh, this is the detection policy, this is the way. This is why the expectations are so high that they are disappointed that we miss this or that condition. So it is more considered rather as a kind of malpractice if they know that your center is able to see cardiac anomalies. In their case, they have not seen it. And you cannot tell them, because the person did not get a nice image and so on. This is why these expectations are going higher. So this is why what we should admit more and more, we have good screening programs, we have good ultrasound machines, there is no excuse anymore. We have years of experience, everything was described, we have books, we have articles, we have ultrasound society, we have know-how. This is why now we come to the weakest point, which is the human. And this is now we realize that we are, let's say, human, and we can also fail, and we need some experience, and not everyone can see the same, and experience can play a role, and so on and so on. This is something where it's now more and more addressed in the era where artificial intelligence is going to support medicine in general and ultrasound in particular. So this is why this is going to be the near future, because when you want to discuss AI, you have to discuss what can a human, or what is human doing wrong or not appropriate. I like this editorial from Edwin Quarello. He worked also with us with the ISUOG guidelines. He's a fetal medicine specialist in France, working in Marseille, and he's working on a special field on artificial intelligence in the fetal heart. He wrote an editorial where he was summarizing in a way what Nisser-Roy paper was showing. He said there are 4 reasons why a cardiac anomaly can be missed. And one reason, and this is, I think, please keep in your mind, the plane required in the guidelines was absent. That means the examination was incomplete. I had a case I've missed some years ago. I look at the images. I said, "My God, what happened to me here?" I saw that I had 2 images of the heart stored, and probably I stopped and looked at something else and forgot to return back. This is happening in everyday's life in many centers. So when you look at cases where anomalies were missed, you will see that can be there. The planes were present, but bad image quality. This is what we discussed also in the quality of the image may be essential. A third point, the planes present, the good image quality, but the abnormality was not recognized. Remember, 30% of the cases were not recognized. And there is a fourth point, as Katya was shown before. Everything was normal, was there, the planes present, and so, but the cardiac anomaly was not detectable. So there are conditions, even if you take your effort, you may not detect them, and this is kind of unavoidable. And what he's trying to suggest is that the first 3 are the one where artificial intelligence can help, because in the number 1, it will tell you you have not stored all images. Please continue until the checklist is completed. The second part is this does not fulfill the quality control. The third part is it may recognize the normality from the abnormality because it is fed with many abnormal cases, even cases you have not seen. So a human being, like a specialist like us, may have seen 1,000, 2,000 cardiac anomalies in his life, but you can feed the system with 10,000 or 15,000 no one has seen in his life. So this is why what he's working on is something like this. So he has for the heart 46 features where this is working in the background. The system is analyzing the images and recognizing this is a tricuspid valve, this is the attachment, this is the shape of the left atrium. And if the criteria are fulfilled, then the system recognizes them as normal. So this is here, could be a future. And if a system is able to analyze images, then look at now what is also feasible. So here, this live examination, but this is more basic. The system recognizes in yellow, it means almost there, and in green means this is the true plane. You see, it is it shown, for example, this is recognized at 3 vessel view. So it will be in the future that will be have a scanning, and the system is recognized in the background, the typical plane. And I'm like when you write in a Word program, the system recognizes your mistake and gives you some suggestion. And I can imagine in soon or late that everything that can be automated will one day be automated. And this is, let's say, something quite normal in my opinion. And I'm expecting that there are companies appearing with such new tools where the patient is scanning with her own, or a midwife will scan at home, and the system is automatically recognizing the typical feature, or it says, no, we don't have quality criteria, there is no enough fluid to be seen, please refer to the doctor. So this is going to be a soon future possibility that our work will be focused only on few cases and not on screening policy for all patients. So I come to the end, and I don't want to scare you, but I want to tell you that AI, and I like this idiom very nicely, because AI is said it will not replace physicians, but I still believe that in future, physicians who use AI will replace those who don't. And I wish you good luck in your cardiac scan, and we'll open now the 2 papers for discussion. Thank you very much.
Thank you, Katia and Rabi, for those 2 absolutely lovely talks. You have mentioned very clearly the challenge that is there ahead of us, that we need literally an army of people well-trained in order to improve the cardiac defects, prenatal detection of cardiac defects. I just will wrap up, I think, because we are run out of time. I will wrap up by saying that in the state of Kerala in India, they did a very nice program, because all women who are undergoing scans, antenatal checkups, their reports were uploaded onto a common software. And whenever an anomaly was flagged, there was somebody sitting there and watching the anomaly. And if it's a cardiac anomaly, they simply tied up with several cardiac centers, and the government allotted this woman that if you deliver, your baby is actually going to go into this cardiac center. By that, they reduce the mortality very significantly, and their perinatal mortality has come to in single digits now. So this is it's not only doing the identifying the diagnosis, but a follow through of the diagnosis, who is going to make decisions, which is actually is the most important thing. So any comments from you, Katia? Last comment, because we have
yes, well, I think that what you said is very important. And I think that in actual fact, in the context of what I said before, the importance of cardiac diagnosis is even bigger in low-income countries, where, let's say, the facility to properly receive and assist the neonate are lacking. So it's very important that conditions are discovered before birth, and that these women are referred to centers with a good perinatal care and pediatric cardiological facilities. I also think that simulation can play a major role. And we know that there are nowadays very cheap simulators that can be bought for a very, let's say, contained amount of money. And that gives the opportunities to sonographers to practice on anomalies, because anomalies are rare. And if you don't work massively, the chance that you will meet an anomaly in your scanning life is rather low. And maybe that day you will be a bit distracted, or you will be tired or whatever, and you will not recognize it. Whereas if you have seen it before, if you have practiced how to recognize it, I think that this will also be key to improve the ability of sonographers to recognize anomalies, and not only theoretical education.
Thank you. Rabi, one last quick question. Artificial intelligence and simulation are these 2 ends of the spectrum, where you provide a very low-cost simulator for somebody to learn, and anybody on the job should log in some simulation time constantly. Is that an option? And will you already said the AI is not going to take over, but it may help, isn't it?
Yeah, I'm sure the AI may help because, I don't want that people are fair, say, oh, AI will take over. But in the meantime, from my personal experience, if I can give a suggestion for some centers, I will do following. I learned from the French system on the French group of doing ultrasound on nuclear translucency. What they did for their audit is not what we do with Kipros to send the 3 best pictures of the year. But what they do, they went to some centers, and we can do it with the nurse, and afterwards you say, take from this week all consecutive images. Let's say, go to a center and say, give me your personal consecutive 4-chamber views of 1 week, and 80% should be of high quality. And if it's not the case, you need to improve until you get 80-85% of fulfilling the whole criteria, because then you oblige yourself to be always good. Otherwise, you may fail your problem. And the second, what I was doing when I was at the university, when I was scanning a fetal heart anomaly, I asked my fellows to come and I let them scan themselves. I said, lady, please, these are the one who will take over when I'm not here, and so on later on. And they were allowed to scan under my supervision that they see in their life how is the plane, how to get the transposition. And for them, it was a wow. For the lady, she was crying because it was sad. But at least I know next time when they have the condition, they will see it because they touch it. And this is something they will not forget. For us, like you and me, if you have seen 60, 80 hypoplastic left heart, doesn't play a role. But for them, the first, the second, the fourth, it's something they will never forget. And this is how to motivate young people.
Okay, thank you very much. Thank you very much, Katya and Ravi, and I thank ISUOG for asking me to chair this absolutely wonderful session. We are run completely out of time. We have gone over time also, and we have to go on to the next session. Thank you very much for this wonderful. And it's my pleasure to introduce the next session. Next session is session 8, and this is on neurosonography. And we have 2 experts, Dario Palladini and Mauricio Herrera. Over to you.
Hello, Suresh. Thank you. Nice to see you all. Can you hear me? Yes, I hope so.
Yes, very well, very well.
Okay. So